Good morning, everyone. Welcome to Pedia Academy by Dr. Pankaj. Myself, Dr. Pankaj, and we are discussing this amazing series on NEET SS previous year's topics. So today we are discussing the important topic of. Okay, today we are discussing clinical evaluation of child with hematuria, or you can say approach to hematuria. This topic underlies the main core concepts of nephrology. We have to begin with hematuria. So what is the definition of hematuria? There are many definitions like RBCs per high power field. So hematuria is defined as presence of five or more than RBCs per high power field in uncentrifuged urine. This should be persistent. Okay, this definition itself is very important. It should be persistent and RBCs should be more than 5 RBCs per high power field in important uncentrifuged urine. So what is the prevalence of this? It is prevalence is 4 to 6%. The important fact to consider, what is normal excretion of RBCs in 12 hour of period in a children? Any guess? This is 5 lakhs. Actually 5 lakhs RBCs in 12-hour period. This is very important. So this interesting fact we will highlight. And again, the hematuria definition itself is very important. Okay, how you will diagnose this hematuria? By and urine routine and urine dipstick test. So there are different classification or definite definition criteria for this. First, we will discuss urine dipstick test. The important thing, what urine dipstick test use the reaction peroxidase chemical reaction. What is sensitivity? It can detect up to 3 to 5 RBCs per high power field in uncentrifuged urine. Pathology suggestion is 10 to 50 RBC per microliter and significant hematuria is more than 50 RBC per high power field. And if you will do microscopic analysis like urine routine, so it will show more than 10 RBC per high power field or 1 plus positive dipstick result. Okay, so these numbers are confusing. Just remember, for hematuria definition, it should be more than 5 RBC. Yes, it is the definition. Okay, then in more than 10 RBC, it is actually seen in microscopic analysis and more than 50 RBC. This is significant hematuria. So just remember these three facts. The, or these features are for unspun urine, uncentrifugal urine, means hematuria definition is more than 5 RBC per high power field in unspun urine sample, more than 10 in microscopic urine analysis, and more than 50 significant hematuria. Okay, we are clear with definitions. Now we'll proceed further. Are there any false negative or false positive results? Means you are doing a test and originally hematuria is there, but we are not able to find in test false negative. Just remember two things: acid and formalin. AF, acid and formalin. If ascorbic acid is there and formalin as a preservative, you will find no hematuria in sample. If there is no hematuria and you are finding hematuria in test, this is false positive. Just reverse this. Alkaline urine causes false positive, and oxidizing agents like hydrogen peroxide exposure uh, produced false positive results. So, differential diagnosis of red urine. If a person getting red urine, there are many differential diagnoses: heme positive and heme negative. Just remember two words in heme positive: hemoglobinuria and myoglobinuria. and heme negative are dietary sources. This is the gross classification of differential diagnosis of red urine. Obviously, there is exhaustive list also. Just look at this list. Other causes of red urine. First is heme positive, second is heme negative. So in heme positive, just two things are mentioned. This is hemoglobinuria and myoglobinuria. In heme negative, there may be drugs, there may be dyes and metabolites. So in drugs, there are list of drugs you need not to remember. Just remember, drugs can also cause red urine, which is heme negative. Dyes like beets, blackberry, blueberries, which can do, and metabolites like homogenistic acid, melanin, methemoglobin, porphyrin, and tyrosinosis. So this is an exhaustive list. Just remember, for red urine, either it may be heme positive or heme negative, and you have to see accordingly the causes. Okay. So, how you will approach the case of hematuria, clinical evaluation approach. So first you will take a focused history of everything like family history, anatomical abnormalities and gross symptoms, that is clear. And second you will do microscopic urine analysis. So for approach, just remember, we'll do simple thing, history and urine examination. So these two things we will do. Okay. In urine examination, if it may be upper urinary tract or it may be lower urinary tract source of hematuria. If it is upper urinary tract source of hematuria like nephrons, glomerulus, tubular, systematic or interstitium. So what are the features? Urine will appear, just remember, brown, cola color, tea color or burgundy color. The proteinuria will be more than 100 milligram per deciliter, positive dipstick, and RBC cast, deformed RBCs will be seen. It is glomerular origin of this hematuria. If it is tubular origin, you will also see leukocytes in urine and renal tubular cast. So, in upper urinary tract source of hematuria, you will see brown cola colored urine, proteinuria, RBC cast, deformed RBC, leukocytes in urine and renal tubular cast. If it is lower urinary tract source, that is pelvic calyceal system, ureter, bladder or urethra, you will see gross hematuria, which is bright red and pink in color and may occur as terminal hematuria. Blood clots may be present, RBC morphology will be normal, and proteinuria will be minimal, typically less than 100 milligram per deciliter of dipstick. So, this is beautifully shown in this table. If urine is cola colored, proteinuria is more than 30 milligram per deciliter, RBC casts are present, and acute nephrotic syndrome features are present, we are clearly dealing with glomerular hematuria. If these features are not present, means this gross hematuria is there, proteinuria is less than 30 and no RBC cast. So we are dealing with extraglomerular hematuria. So this is diagnostic algorithm. We'll discuss it later, but as of now, just remember, we'll do CBC, routine, cholesterol, ASO, ANA. We will do accordingly causes of this hematuria. Extraglomerular hematuria, we will do urine culture, urine calcium, urine analysis, and so on. Basically, this will be directed by cause, particular differential diagnosis of hematuria at that time. Okay, so causes of hematuria in children, there is exhaustive looking table. Just remember, just try to remember. Okay, so there are actually upper urinary tract causes and there are lower urinary tract causes. Just remember these two things. Okay, for lower urinary tract inflammation, cystitis, urethritis, trauma, coagulopathy, heavy exercise, bladder tumor. So in these, the fresh blood will be seen. Okay, proteinuria will be less, RBC morphology will be normal. This is differentiating feature and these are the causes. Upper urinary tract, it may be of renal disease isolated, It may be multisystemic disease, it may be tubulointerstitial disease, vascular disorders, and anatomical disorders. Don't mug up this list, but just remember any renal disease like IgA, Alport syndrome, nephropathies are associated with this. In multi-system disease, SLE, IgA vasculitis nephritis, granulomatous polyangiitis, Goodpasture syndromes are part of it. And tubulointestinal disease like pyelonephritis, papillary necrosis also part of this. Vascular disorders like arterial and venous thrombosis, malformation, anatomical disorders like hydronephrosis and polycystic kidney disease. So this looks exhaustive, but this table is very simple. Okay, so this is just a repetition of this. If you are able to see T, cola colored urine, edema, hypertension, oliguria, basically we are dealing with glomerulonephritis, which is the one of the common cause of hematuria in children. So in under umbrella of glomerulonephritis, this is PSGN, IgA nephropathy, MPGN, IG vasculitis nephritis, SLE are there. Other things like granulomatous and polyangiitis, like okay, sorry. Other thing like granulomatous polyangiitis, microscopic polyangiitis, Goodpasture syndrome, and HUS. Okay, you can get diagnostic clue from history. If recent infections are there, then you have to think of PSG and HUS. Rash and joint complaints are seen, so you can go for IgA vasculitis and SLE nephritis. Okay, you are if you are able to see painless hematuria, mostly associated with glomerulonephritis. Frequency, dysuria, unexplained fever, suggestive of UTI, renal colic, nephrolithiasis, and phlegma, suggestive hydronephrosis, cystic disease, RVT, renal tumor. Okay, trauma history may be there, family history may be there. Okay, just history point of view. So this is genetic predisposition. General signs like hypertension, edema, glomerulonephritis, syndromic association, Vetter syndrome, abdominal mass like bladder distension, hydronephrosis, polycystic kidney disease, Wilms tumor, and other conditions, genital abnormalities. Okay, now we will move to gross hematuria. It is very concerning with parents. Parents are very concerned. So, what are the causes of gross hematuria? UTI, this is actually most common cause of gross hematuria in children, which is very much important. What are the other causes of gross hematuria? Like meatal stenosis, perianal irritation, trauma, urolithiasis, hypercalcemia, this is important, coagulopathy, PSGN, IG vasculitis nephritis, IG nephropathy, Alport syndrome, SLE. We will discuss some of the individual disorders with gross hematuria in detail in upcoming lectures. But as of now, just remember these highlighted or marked conditions. So, parental anxiety is the important part in gross hematuria of OPD visits. Common causes, as we discussed, bacterial viral UTI are most common frequent cause. Again, the one entity is very important, that is called as urethroresia. What is it? This is bleeding from urethra without urine, present with the dysuria and blood spots on underwear after voiding. So what is this? This condition we have to remember as a pediatrician. So what is the significance? This condition typically occur in prepubertal boys at infrequent interval, and generally this is self-limiting. Okay, this was for gross hematuria. If we are facing this condition, recurrent gross hematuria, this is important consideration, and every pediatrician should know what are the causes of recurrent gross hematuria. IG nephropathy, Alport syndrome, thin glomerular basement membrane disease. So these three conditions, which are very much important, are associated with recurrent gross hematuria. Okay, so uh, again, asymptomatic microscopic hematuria, if someone able to find, often it is transient. If it is persistent, means at least 3 urinalysis for 2 weeks. So it may be called as persistent. How you will diagnose urine culture, spot urine test, and sickle cell screen. Okay, so structural lesion you will see, USG you will do, and if USG is normal, serum creatinine and electrolytes you will do. Okay, so in this hematuria, are there other hematological abnormalities associated? Yes, anemia is associated, which is hypervolemia with dilution. This is the most common cause. Decreased RBC production in CKD and hemolysis like HUS, chronic hemolytic anemia and SLE, and blood loss. So these are the causes of anemia in cases setting of hematuria. Okay, PBF you will find microscopic microangiopathic process like in HUS and autoimmune markers you can able to see. Thrombocytopenia is due to malignancies and increased platelet consumption in various disorders. Okay, so uncommon causes of hematuria like bleeding, diastasis, coagulation studies are there. So, what you will do by to diagnose these conditions, it will depend on localization of these conditions like voiding cystourethrogram for UTI, renal scarring, hydroureter or pilogalactasis, cystoscopy. This is actually any bladder mass or any ureter abnormalities, tumor. So, uh, management and follow-up is very important as per BG OPD practice of pediatricians. So, if you find a patient with asymptomatic, persistent, isolated hematuria that is more than 2 weeks, it will code as persistent. So, you will do blood pressure and urine test every 3 months until resolution. So, this is very important. You have to call that child or patient every 3 months until resolution. Okay, so if you found it is going more than 1 year, you have to refer this patient to pediatric nephrologist. Are there any indication of renal biopsy in hematuria? Yes. Persistent microscopic hematuria in certain cases, recurrent gross hematuria associated with decreased renal function, proteinuria, hypertension. These are important consideration for this biopsy. So this was a short and sweet topic of approach to hematuria. It is very much important, and just remember the diagnostic algorithm and the classification into glomerular and extraglomerular, causes of hematuria in children, causes of red urine in children, along with meconium ileus. We'll discuss some another topic of this amazing series. Till then, do share, like, and